All right, everyone, I'd like to welcome you here tonight to our online seminar. Just a quick note before we start, this session is being recorded and we'll share it on our YouTube channel later. To help keep things running smoothly, please make sure your microphone is muted, and if you have any questions, feel free to drop them in the chat box. So we're very lucky to have with us Professor Richard Gearry, a leader in the field of gastroenterology. He's a professor at the University of Otago, a consultant gastroenterologist at Christchurch Hospital, and a medical advisor for Crohn's and Colitis New Zealand. His research interests include IBD, celiac disease, irritable bowel syndrome, and colorectal cancer, all areas that directly impact so many people. Tonight, he'll be sharing insights on Upadacitinib, a JAK inhibitor recently funded by Pharmac as of May 1st, a development that offers new hope for IBD patients in New Zealand. We're grateful for the chance to hear from him. Richard, thank you very much for being here tonight and giving up your time to talk to us. So I'll hand it over to you now.
Thanks, Belinda. So thank you for the invitation to come and give this talk tonight. I'm really excited to be able to do that. And certainly from my perspective, this is all about sharing knowledge. So I'm not pretending I know everything. And it would be good also for people to ask questions and throw stuff in the chat so we can have a good talk afterwards. I'm not just going to talk about upadacitinib, but I want to give a bit of context as to the background by which upadacitinib is arriving on the scene, because you'll have seen this week there's been a bit of media attention around IBD and a big study that was done around the world to look at how common it is and what's going on. So I'm just going to go through that as a bit of a background before we start, just because I think it's quite topical based on the fact that there was stuff on the media in the media this week, and some of your friends may have asked you about it, and I thought I'd just give a brief overview, but I'm happy to come back some other time and do that. I'm also looking sideways and admitting people at the same time who are arriving, so my apologies for that. Okay, so as with any talk, we always give our disclosures at the start, and that's really important because I am talking about a drug here, and you can see here that that I've received research support from a range of companies, including AbbVie, who market upadacitinib. They've never given me any upadacitinib, and certainly I don't believe that I would prescribe it more because they've done that or anything like that. But it's just important that we declare that up front so that you understand where that's coming from. And then there's other bits and pieces of stuff that I do as well. All right, so I think some of you may have heard in recent times about this whole idea of the different stages of IBD around the world. And I just wanted to talk about this briefly before I get into the UPA talk. So this is the stuff that came up during the week from this big study that was published in Nature by Lindsay Hrax and others. So essentially around the world, there are different stages of IBD. So very early on, we get a few patients being diagnosed, this emergence where one or two cases are there. But then over time, all of a sudden, we get this massive increase in the green in incidence, where incidence means the number of new cases each year, and that goes up very, very quickly. And then prevalence goes up as well slowly after that. And in New Zealand, we're in this stage where incidence has plateaued, but prevalence continues to go up. And I'll show you what that means in just a minute. And here are the different stages, and you can see here the different number of patients being diagnosed in different parts of the world. And we've been able to model this across the whole world, so we know what's going to happen in the future to other parts of the world, which is sort of exciting, but also quite scary. These are the data from Canterbury, and these are data from Angela Forbes, who's done a fantastic PhD. It's currently being examined, looking at the epidemiology of IBD in Canterbury. Now, the reason we've done Canterbury is that that's where we're from. It's easy for us to measure it there, but there's no reason why what's going on in Canterbury shouldn't be the same as other parts of New Zealand as well. So if you look at the top left slide, graph, sorry, what you can see here is the number of patients in Canterbury with Crohn's disease. And you can see here in blue, we've got males, and red females, I think, or sorry, I've just got some stuff over the slide. And you can see here the black line. And what you can see here is that most people with Crohn's disease in Canterbury tend to be in this 20 to 30, 40-year age group. As you can see here, the Crohn's disease population is a little bit older overall. But if you combine the two together, and what you can see on the right here in the black square, you can see that We have up to 1% of patients with IBD in the population with IBD. And where we think we're heading with IBD in the long run is to have probably 1% of the population with IBD. So that's 1 in 100 people. And obviously, that's an enormous increase over the years. And in Canterbury, what that means is, for example, from 2005, when I did my PhD, 2004, we had 1,420 people in Canterbury. Now we've got over 4,000 people in Canterbury with IBD, and we think we're heading towards about um, probably five, 6,000 people with IBD in the population. So it's a lot more IBD than there used to be. And what that means is that obviously we need to have good ways of managing people with IBD to ensure that we're doing the right thing and looking after them. So why is this important? Well, IBD can be chronic and progressive. So people with IBD can have repeated flares of their disease, that black line over time, where they're having flares and then it settles flares. But over time, especially with Crohn's, but also with UC, you can get complications such as strictures, which are narrowings of the bowel, or abscesses and things occurring, which means that damage is occurring over time to the digestive tract. And this is the concept that's been around for a while. So, with that in mind, over the last 5 to 6 years, we've been undertaking this strategy, which is called STRIDE, or it's a treat to target strategy, where if someone's got active inflammatory bowel disease, we determine the therapy they need according to their risk of progression. We then aim to improve their symptoms, and if that happens, we move on to the next step, which is we will try and improve their blood tests. And if that is okay, we'll then try and improve calprotectin in their feces and then try and improve endoscopic appearances. If we can't do that, we need to go back to the start and pick a new treatment. So, this is why having more treatments is really important because we need more treatments to be able to treat people who don't respond to other treatments that we might have. And that's why new developments in IBD have been so important. But the issue with IBD is that it's not just about disease inflammation, not just about inflammation, but also there's about complications of the disease. There's also these other impacts on a range of things for patients, and also the effect of the healthcare system. So, with that in mind, while we always think about inflammation, sometimes it's not inflammation that might be driving your symptoms. So every time I see a patient in clinic, I always think, well, are your symptoms due to inflammation, or could it be due to an infection, or do you have irritable bowel syndrome? Do you have a range of other things that could be causing your symptoms? And that's important because I don't want to give someone drugs for inflammation if they've got other causes for their symptoms. So just putting this in context, I suppose, before we talk about the new drugs. So how do we know if your symptoms are due to inflammation? Well, we want to know what the symptoms are. We can do blood tests and fecal tests. Increasingly, some places around the country are using ultrasound to look at the gastrointestinal tract, CT, MRI, and endoscopy. These are things that you know about. And the reason we do these is that if we've got signs of inflammation, it means that we know that that's the right thing to treat rather than something else. So, what treatments do we have for IBD? I'm just going to try and put all this together now, if you like, to try and understand exactly where these different drugs fit. So, where are we? We've got drugs, and that's what we're going to talk about a lot tonight. Now, drugs are important, but I just want to stress to you that for a lot of people, drugs aren't the only thing you'll be treating. For some people, understanding more about IBD will help because you can rationalize your symptoms and understand what's going on. And that's where engaging with events that CCNZ hold become really important for what's going on. We've also got complementary alternative medications. I can't spell, sorry. We've got diet changes, and for some people, they'll need surgery as well. In addition to that, psychological support is really important and something that I think we're lacking majorly in New Zealand. Lifestyle factors such as exercise, and then support from those around you. So, although we're talking tonight about drugs for IBD, remember the treatment for IBD is much broader than that. And there are often other things that you can look at to try and improve your symptoms, albeit tonight we're talking about drugs. But didn't want to talk about drugs and ignore everything else. Okay, so we're now going to start talking about the different individual drug classes that we have for IBD and where they might fit in the paradigm altogether. So the first drugs that you might know about are the five ASA drugs. So these are drugs like pentasa, azole, sulfasalazine, oxalizine. Now they're mostly used for ulcerative colitis. They're mostly used for that condition. They don't really work as well in Crohn's disease in general, although occasionally we will use them. These are drugs that are a delayed release oral drug, so they're big tablets and you swallow them. They're protected from the enzymes. They break down and release on the way through the gut, or you can have them as an enema or suppository. They're very good for colitis. They're generally safe, but they really just work for more mild disease. They're not so good for really aggressive, active disease. Okay, sorry, just get organized. Okay, steroids. So steroids can be intravenous. So if you're hospitalized, you may get hydrocortisone. They might be oral, prednisone or budesonide or cortimant, or they could be rectal in the form of colophone. So these are really, really good drugs at getting you well. But because they've got lots of side effects, they've got no role at all at keeping you well. So we can't maintain remission. We can't keep you on steroids for a long time. It's not good practice to do that. They've got lots of side effects and certainly good as a short-term fix, but you need to have a way of getting off them. Then you might know about these immunomodulator medications, azathioprine, mercaptopurine, thiaguanine, methotrexate. These are immunomodulators. They have a really slow onset, so they're no good to get you well because they take too long, but they're quite good to keep you well in the long term. And they're sort of the anchor drugs that we use for Crohn's disease, certainly in the past. They do have some side effects though, and you need to have blood tests regularly, and some people don't tolerate them so well. We now move from those older therapies to the advanced therapies. And I'm going to talk about these together, and then we're going to go through some of these individually. So you'll know about the anti-TNF alpha drugs. These are drugs like infliximab and adalimumab. So these are the drugs that we've had in New Zealand now for 25 years, infliximab, and about 15 to 20 years for adalimumab. So initially we had Remicade. We still have Remicade in New Zealand. There is Remsima, which is around, and that's a subcutaneous infliximab, which is interesting. We used to have Humira, and then the government, Pharmac, sorry, changed the funding to Amgevita. So Humira is still about, but most people have been switched to Amgevita. We've got the anti-integrin drugs, such as vedolizumab or Entyvio, really good, safe drugs, which are great. And Stelara and Entyvio were both funded around the same time in about 2.5 years ago now. And certainly our experience has been they've been very good drugs for a lot of people, not for everyone, but for a lot of people. And for those drugs, they've got really good safety profiles. And the JAK inhibitors, of which upadacitinib is, I can't even spell upadacitinib, there should be an I in there. Upadacitinib or Rinvoq is the drug that's now funded in New Zealand, which we're talking about tonight. And there are some other drugs that aren't available in New Zealand. So we look at these. There are also lots of biosimilars for these drugs, which means that there are copy drugs like Amgevita is a copy of Humira. So lots and lots of those around. And there's even a possibility of these being tablets in the future. For ustekinumab, there's also a whole range of other drugs that are around elsewhere. They're not necessarily, some of them are registered overseas, some aren't. So these are drugs that, again, might be a bit better than ustekinumab, we think. And then there are other JAK inhibitors. So this class of drugs, upadacitinib is called a JAK inhibitor or a JAK-I, you can see there. And the other ones that are around at the moment are tofacitinib and filgotinib. And they're available overseas, not so much in New Zealand. And then there are some other drugs that I'm not going to talk about tonight that aren't available in New Zealand. All right, so this is a timeline of when all these drugs became available. Just to give you some context. So back in the day, 1955, this is one of the first randomized controlled trials that started saving lives for people with acute severe ulcerative colitis. Often back in these times, it was a highly fatal disease. People might die, and steroids saved people's lives, and it was a landmark study. Over time, new drugs came along, such as topical steroids, sulfasalazine, oral steroids, and azathioprine in the 70s, and this is a big deal at the time. Subsequently, these drugs were used more with mercaptopurine, methotrexate, the 5-ASA drugs also being used for ulcerative colitis. But at this point here, we reached the biologic era where we've got these MABs. You see these drugs are all called MABs. And what that means, it's a monoclonal antibody, which means that it's a protein that's been developed in the laboratory that binds to a chemical or a cytokine in your blood that drives inflammation. And by binding to it, it neutralizes it so inflammation doesn't occur, and that improves your symptoms and you feel better. So that's this. All these MABs came along. So infliximab is the drug that we've had for a long time. We like it. It's really good. Know all about it. Then adalimumab, first Humira, now Amjevita and Humira. Then vedolizumab, again, look, came along in 2013, and by the grace of God, Pharmac gave us access to that drug in 2023, 2022, 2023. Ustekinumab as well around that time. And then you can see here tofacitinib. So these are the nibs, which are the next class of drug that came along. And we've got tofacitinib, filgotinib, upadacitinib, all there. And then there's some more MABs here as well. So you can see it's come from sort of a range of things here to the MABs, then the nibs, and we've got some mobs here as well. So it's all very alphabet soup, if you like. And that's where we fit in. So in New Zealand, we've got infliximab, we've got adalimumab, we've got vedolizumab, we've got ustekinumab, and now we've got upadacitinib. So there's lots of things we don't have, but I must say that this combination now is really good. We'd love probably one of these ones over here as well some stage, but we can live without those for now because we really, really wanted this one. All right, there's not going to be an exam at the end of this to ask you how to pronounce all these cytokines and things, but what I really wanted you to show here is that these drugs have got real reasons why they work. So vedolizumab blocks these white cells from going from the blood into the tissue. You can see here that infliximab blocks TNF alpha in this area here. You can see that that upadacitinib works on these JAK inhibitors, and I'm going to show you this in a minute. So there are really very clear reasons where these drugs work, with lots of science and behind them to explain what's going on. These are the drugs we've got in New Zealand. All right. So now I'm going to finally talk about upadacitinib. What's that, about half an hour into the talk, not quite 20 minutes. But I just wanted to give some context as to where these drugs fit. And I'm going to throw some science at you. If you don't like science, just switch off for a while and nod your head and say it looks pretty. But I just wanted to show some science because it's important to understand how these drugs fit in. So essentially, this is the lining or the membrane of a cell, and these are receptors on a cell, these different areas here. You can see the receptors are made up of either TYK2 or different JAK2, JAK1, JAK1, JAK2, JAK3, JAK2, JAK2. And essentially what happens is that these different molecules come in and they stimulate these receptors, and this enables STAT proteins to bind here, go to the nucleus and block the production of inflammatory cytokines and block all these things down here. Now what happens is that JAK inhibitors block the signaling here, and you can see here the names of different JAK inhibitors, and you'll see that some, such as tofacitinib, and I'm not even going to try and pronounce that one there, block the whole lot. So that sort of sounds good, but the problem is you get lots of effects that aren't targeted at the disease. Whereas UPA's got a much narrower target here, just in these ones here, by hitting these selective JAKs, and that makes it a bit more specific. So for that reason, if we had to choose a JAK to get in New Zealand, a JAK inhibitor, that's why we really like upadacitinib. It's a bit more selective, and also, as you'll see in a minute, the trials look pretty good. So that's how these drugs work. I had a video, but I thought I'd spare you. All right, so does upadacitinib work for Crohn's disease? I'm now going to show you some slides, and I saw there's some people from AbbVie here, so please close your eyes because I don't know whether I'm allowed to show these slides to patient groups, but it's data that's in the public domain, and I think from my perspective, it gives a good explanation of what's going on. Again, there's a bit of science here, not so much molecular science like I showed you now, but more clinical science, showing you how we do the studies and what goes on. So these are the studies for Crohn's disease. You see UXL and UXC. They give great names to these studies. You can see here they put over 1,000 people in these studies, and they were randomized to either get Rinvoq as a 45 milligram tablet once a day, or placebo, a dummy tablet. And again here, two different studies in the same way. And if you're on steroids, you had to come off. Then, if you responded, you were then randomized to either two lower doses of Rinvoq or upadacitinib or placebo, and then if you did okay with that, then you went into this study here and you were watched out in the long term, out to 4 years, to give some data as to what's going on. So this is the program of studies that was done. You'll see here, 1,000 patients here, 500 patients here, 350 patients here. They're big studies from patients who are recruited from all around the world. This is a big, big deal. So what were they trying to find? They were trying to find, could patients go into clinical remission? That meant the stool frequency was less than 3 per day and the abdominal pain score was less than 1. They're just scores, but to give you some idea. And you had to reduce the amount of inflammation in your gut by 50%. That's the endoscopic response. So these were co-primary endpoints. You had to get both of those things for the drug to be effective, and that's pretty tough. So did they work? Well, in the induction studies in the first 12 weeks, you'll see placebo was quite good. 1 in 5 people responded to placebo, and you'll see that 1 in 6 people responded here. But compared to placebo, there was a significant benefit of about 40 to 50% of people felt better, significantly better, and they got improvement in inflammation. And if you then continue out to a year, about half or more of those people will continue to benefit. So this drug works. Now, the other thing I'd say about this drug is that a lot of these patients had failed lots of other drugs. So they weren't patients who had had no drugs. They were patients who had failed drugs. And as a group, patients who have failed drugs are harder to treat. It's harder for us to do well. So these are pretty good data. This is looking at some other impacts of remission, looking at a range of different scores, response, endoscopic response, etc., showing that the drug can persist out to 2 years or more at these doses. So, does upadacitinib work for ulcerative colitis? Again, similar studies. Again, the best part of 1,000 patients, give or take, 2 different studies. 45 milligrams once a day, 45 milligrams once a day here. Then after 8 weeks, people who responded were given 30, 15 or placebo. And then they were followed out there, as you can see, out for longer to see, does the drug work? So this is a whole study program here. So what were they looking at? The primary endpoint was clinical remission. So did they feel well? So a stool frequency of less than or equal to 1 per day, not greater than baseline, no rectal bleeding, and no ulcers in the gut, and healing of the mucosa as a secondary endpoint. What did they do? Well, at 8 weeks, a quarter or a third of people with ulcerative colitis reached those endpoints, and subsequently a half could continue to do so out to a year. So again, reasonable data for ulcerative colitis that this drug can be effective. And what about mucosal healing? Well, yes, it could heal the gut. So the gut could be healed completely, and up to about 45% in those studies. And that continued out in quite good numbers as well subsequently. So these drugs do work. You can see this is placebo here. And you can see why we need to do placebo studies, because this is all about comparing these two, the grey with the yellow, to understand that the drug is better in a blinded way. So the people who were taking the drug didn't know what they were getting, and the people who were prescribing or giving the drug to people didn't know what they were getting either. So it's completely blinded. No one knows what's going on. And again, these other things work pretty well. Okay, so that's all good and well. The drug works for many people who take it, and no drug is perfect, but is this a safe drug? And that's the thing we worry a lot about, because obviously if we're going to prescribe this drug, we need to know that we're not going to harm people by giving it. So here's the data for the Crohn's disease study. And you'll see here, these are the data in the grey for the placebo, for the 15 milligrams and the 30 milligrams here. So this is out to a year. So any adverse event, 75%, 74%, 76%. So even getting placebo, people get an adverse event. And this can be anything, like you can get a virus or anything, it could be the case. But the most common side effects that people get are worsening of their disease, because that can happen with any of the treatments. But there's a number of other things that you can see there that might come up again. Death didn't happen in this study, which is great. Adverse events leading to discontinuation, slightly more in the drug arms, and these ones here, serious adverse events, actually less overall than in the placebo. So, pretty good safety profile, but we can't say anything's perfect. What about out to 2 years? Again, we can see here that using these, we see no new safety signals from the drug out to 2 years with any other things occurring there. What about ulcerative colitis? Again, any adverse event, the rates are relatively similar between the two. Serious adverse events, slightly more in the treatment arm, but no new safety signals or different things. Now, there are some things that people were really interested in because of earlier studies. So these were sort of selected adverse events of special interest. And the first one is this one, acne. So as a class, the JAK inhibitors can cause acne, especially at the higher doses. In fact, people who know these drugs call it JAKNI as a bit of a acronym or a bit of a some sort of play on words, if you like. So up to 1 in 20 people will get 120 people will get acne, and certainly we've got ways of managing that. And the good news is that dermatologists also use this drug, and of course dermatologists have got good ways of managing acne as well. It can put up one of the blood tests, but not significantly. The big one we worry about is this one here, which is herpes zoster. So herpes zoster is shingles, or you'll know it also as chickenpox or varicella zoster called chickenpox. But in adult population, it's mostly zoster. Now, shingles can be a really horrible thing. It can be not too bad, but it can be really horrible, causing pain and rash on different parts of the body. So this here shows that in the UXL study, for example, one in 20 patients got herpes zoster, which is pretty high. Now that's reduced if people get vaccinated, but the only vaccine that works or is safe is Shingrix, which is the live vaccine, and there is a cost to having that of about $700, which is not insignificant. So at the moment, for patients who I prescribe this drug to, I say to them, I strongly advise you get Shingrix vaccination, but I also understand if people can't afford it. And this is something that Belinda's going to talk to you about at the end of this, because we want every 44 people on the call to contact Pharmac about this. Because if you had rheumatoid arthritis and were prescribed this drug, you get Shingrix for free. And that's not right. So we need to sort that out. Serious infections, again, there are some serious infections, not really much in the way of cancer. No other clots, which has been a concern for some people. No other cardiovascular events like heart attacks, and no signal for perforation of the gut. Again, looking at selected events in the ulcerative colitis study, acne in about 4%, CK elevation slightly there. You can see herpes zoster 1 in 25 infections, so on and so forth. But in general, we're pretty happy with this. So Rinvoq is the name that the company give the drug, also known as Upadacitinib. It's got a fantastic name that no one can pronounce. You can see here, this is the indication, this is what they basically are allowed to have the drug given for. And you can see for ulcerative colitis, it's indicated for the treatment of adult patients with moderate to severely active ulcerative colitis who have had an inadequate response, loss response, or intolerant to conventional or biologic therapy. And for Crohn's disease, if you've got active or severe disease. So that's what the indication is, but this is what they are allowed to have it prescribed. We can prescribe it for and have it reimbursed for by Pharmac. So for ulcerative colitis, active ulcerative colitis who have failed to achieve an adequate response or was contraindicated or intolerant to a prior biologic. So that's infliximab, adalimumab, vedolizumab, ustekinumab. So any one of those drugs, if you failed it, you could then go on to Rinvoq if that was the right drug for you, and it may or may not be, and that's a discussion to have with your doctor. For Crohn's disease, it's funded for active Crohn's disease who fail to achieve an adequate response or contraindicated intolerant to a biologic therapy. So very similar between the two. So what this means, it's a second line drug when it comes to advanced therapies. You can't go onto it straight away, and that's where it sits. Okay, so what if you had Crohn's disease and were starting this drug? What would it look like? Oh, you'd see your doctor. Hopefully, your doctor would say you should get a Shingrix vaccine because that's what you should get. You would take that on board and make your decision about that. You get a special authority number. And then, unlike the other medications such as infliximab, adalimumab, ustekinumab, vedolizumab, there's no infusions, there's no injections. We just write a prescription. We get a special authority and write a prescription for 45 milligrams once a day. You have that from week 0 through to week 12, so for 3 months. and that's the induction phase. At that point, we should be reassessing you to determine, has induction worked? Have we actually been able to get you well? And if we have got you well, that's great. And then we want to maintain you on a lower dose. And that could be either 15 milligrams a day or 30 milligrams a day. And obviously, we always want to use the lowest effective dose. We don't want to give people too much drugs, but we can modify the dose between these two doses as well. So that's what it looks like for Crohn's disease. For ulcerative colitis, we use 45 milligrams a day for 8 weeks. If people weren't responding at 8 weeks, you can continue on that dose up to 4 months or 16 weeks, and then subsequently again switch people to a maintenance drug dose of this. So these are tablets, and that's how it works. That's how the prescription works. What about the drugs? You can take them. Someone asked me today this question, hopefully on the call. They can be taken with or without food, once a day, about the same time each day, and don't crush or split it or chew it. Just swallow it. So this is a horrible slide, but I've just tried to put together my view. These are my views, not the views of the companies or anything else, as to where these drugs fit in terms of everything else. So I'm going to go through it line by line. So the thiopurines are azathioprine, mercaptopurine, and thioguanine. They work, but they're not the best drug we have. They're sort of safe. They're not immunogenic, which means that your body doesn't have an immune response to them. They're a tablet. They work very slowly, so they're not a drug to use if you want to use it fast. They don't work for perianal Crohn's disease or fistulas around the bottom. They're super cheap. They don't work for psoriasis, which can go with this. They're safe in pregnancy, as much as we know. They don't cause clots. They may predispose to shingles, and they don't predispose to acne. Methotrexate only works for Crohn's disease. It's sort of safe, but not super safe. It's not immunogenic. It can be given subcutaneous or intramuscularly, and there's some data for oral treatment as well. It's slow to work. It doesn't work for perianal Crohn's disease as much as we believe. There's no studies to back that up. It's super cheap. There is some activity in psoriasis. You cannot use it absolutely under no situation can you use it if you're thinking of getting pregnant. So for young women, that wouldn't be a drug that we want to use. We don't believe it's associated with clots. It may be associated with a little bit of shingles, and it's not associated with acne. What about infliximab? Works really well. Great drug. Is it safe? Well, it's got more safety issues than it's got some safety issues with it. It's immunogenetic because it's a protein. The body's immune system can see it and modify it. So often we prescribe infliximab with one of these other drugs. It's given intravenously at the moment in New Zealand. It works pretty quickly. It does work for perianal Crohn's. It's probably the best drug we have. It cost has dropped a lot, but it's still more expensive than these. It works for psoriasis. It's okay in pregnancy, as much as we know. No sign of clots and so on and so forth. Adalimumab, really very similar. I'm not going to go through that, but very, very similar. Stelara or ustekinumab, again, it works. We're pretty happy it's a safe drug. It doesn't need an immunomodulator such as these drugs to be prescribed with it, which is good. They've been given IV, then subcutaneously every 8 weeks at home, so that's pretty good. Works pretty quickly. It may have some activity for perianal disease. It costs more. It does have some activity here as well. Vedolizumab does work. It's really safe. Not immunogenicity. It's given intravenously low, so you've got to go into the hospital to have it given every 8 weeks. There is a subcutaneous formulation, and we'd love to get access to that, Pharmac. It does work, although not super fast, and you can see there. Then upadacitinib is this bottom line here. So compared to the others, it does work. We believe, looking at studies from overseas, and there aren't really any good head-to-head studies, but the real-world evidence would suggest it's amongst one of the better drugs that we have from an efficacy point of view. Safe, it's probably safe, but I did go through some of those things that we're concerned about. It's not immunogenic, so we don't use it with azathioprine or methotrexate. You're just having this and really nothing else. It's oral, which means it's much easier to give than some of these other drugs here. It can work really fast. Now, it doesn't work for everyone, but it works probably as fast as steroids do, which means that there's even some studies being done now of people with very severe disease in hospital getting upadacitinib. Now, that's not on label, but it is something that is being studied at the moment. We don't know if it works for perianal Crohn's disease, but there are some suggestions that there may be an effect. And of course, that's a group of patients that do need some options. It may have some activity for psoriasis, and these are the issues down this end, which are the shingles and the acne. So I just put that together sort of as my feel for what's going on. It may be what other people may disagree with me, but this is where they fit together. And I suppose what I'm saying is that UPA isn't for everyone, but it's certainly for people, and there are some aspects of it that make it quite attractive for some groups of patients. So where does upadacitinib fit in New Zealand? My opinion again, well, it's indicated for moderate to severe Crohn's disease or ulcerative colitis. It can only be used as a second line option after one of the other advanced therapies, which is one of the MABs. And I think it's a drug that might be really useful where oral therapy could be seen as being an important therapy. If people don't have IV access, if there's issues with needles, if there's a whole range of reasons. Because it's a new drug, we don't have as much long-term safety data. That's just the way new drugs are. We can't go into the future. We really need to get Shingrix vaccination over the line. We need to lobby Pharmac. We need to tell them what's so special about rheumatoid arthritis. IBD is as important, and we need not to be discriminated against. And as a group of gastroenterologists, we're really happy to have access to this new treatment because it's a new mechanism of action. This drug works in a different way to the other drugs. And what it will mean is that some people will respond to this drug when maybe they didn't respond to other drugs in the past. So we're really happy to get this drug. So that's all I had to say. But hopefully there's some questions. I'll just